Hello everybody. So in today's video we are going to be going over your respiratory system objectives 11, 12, and 13. So we're going to be talking about the various different names for different types of air that could be within our lungs and how doctors measure these and why it's important to be able to measure these. So there's going to be a lot of definitions and some math formulas in this video. You guys will be responsible for answering one math question on your next exam, and it's going to be from one of these math formulas kind of deal. However, it's all addition or subtraction, so this isn't going to even hit the algebra 1 level of stuff that your cardiovascular system test did, but this is still stuff to be aware of and know, right? So Objective 11 is define, compare, and contrast the various lung volumes and capacities, which we're going to go over all of those definitions and compare them. Objective 12 is define and explain the importance of dead space. And Objective 13 is describe pulmonary function tests and explain the type of information gained from them, which is why all of this intertwines nicely together. Objective 11, you have to understand these definitions and compare and contrast them. 13 is why it's medically relevant, right? So here we go. There are different types. We all know how to breathe in and out now from our previous videos and how we physically breathe in and out, how that works. So we need to understand that we have different terms for different air levels that could be within us and how that goes in and out. And in knowing the difference between these terms is going to help us diagnose different problems that could arise within breathing, right? Because there is a vast difference when you start talking about a small child with asthma and how you would treat them. We discussed asthma in our last video, versus that lovely elderly gentleman who didn't know smoking was bad for him in the 1950s, and now he has COPD or emphysema and that kind of thing. Treatments are going to be very different based upon what we need and for our lungs to function properly, right? So we have to understand all of these different thresholds. And we have different names for a lot of this, right? And we know that air, just like with a balloon and most other things in chemistry, goes from the highest concentration to lowest concentration, or high pressure to low pressure. It's going to flow down the pressure gradient, so to speak, right? So naturally, air is going to flow from a high pressure to a low pressure environment, which is why if you pop open a balloon, the air will flow out, right? Because the air inside the balloon, where you have pushed all of the air to stretch latex out and fill your balloon, is at a higher pressure than the air in the world around it. So it's going to want to slowly leak from a tied balloon out into the world, or if you if it's not tied and you just let the balloon go, the air pressures will even out, right? Quiet breathing is your normal breath when you're not thinking about it, right? So quiet breathing is just your normal breathing, probably what you were just now doing until I mentioned that it had a name, while you're sitting on the couch watching Netflix or listening to this video, something like that. So quiet breathing is what you're doing when you're asleep. It's when you're not thinking, hey, I need to breathe in and breathe out. It's called eupnea, because when you see things that end in PNEA, that is going to be indicative of a condition for breathing. Like, you've all heard of sleep apnea. This is eupnea because the prefix EU in Greek or Latin, I forget which one it is, means good. Pena means breathing, so this is good breathing. Quiet breathing is just your regular breathing when you're not actively thinking about it. Right? Forced breathing is called hyperpnea, or over-breathing, right? Means in addition to using your diaphragm and intercostal muscles to breathe for contracting and whatnot, You're going to use accessory muscles, including your obliques and scalenes, which were in your abdominals, if you remember from A&P1. So you can contract, and expand your thorax to do whatever you want to. So forced breathing is what I'm doing now as I'm speaking to you, because I know when I have to breathe in, and I know when I have to breathe out, because I'm forcing myself to breathe out in order to speak to you, right? If you are in a choir, church choir, school, whatever, you know how to breathe because you know you can't just be in the middle of that chorus and then suddenly just like take a huge breath in. You have to be able to force yourself or control yourself to breathe quietly so that the other choir members and your audience don't hear you breathing. And so you can sing your full phrases, your full verses, that kind of thing, without taking awkward pauses and breaks in between them for you to catch your breath. All singers need to do that, be it in a choir or, God forbid, solo artists have to do that, because it gets awkward if a solo artist does not do that. Musical instrument players and that kind of thing also need to be able to control their breath for the exact same reasons. That kind of thing is called forced breathing. Right? So the next question is, how are we going to determine respiratory volumes and all that kind of stuff? When an individual has difficulty breathing, medical staff are going to need to be able to measure different air volumes within their lungs and the amount of air being inspired or expired, breathed in or breathed out. So when you start having breathing problems and something is very, very wrong, doctors are going to want to measure a few different things. They're going to want to measure your different volumes of air inside and outside, and how well you can take it in and get it out, right? A spirometer is used for these calculations. There are some super simple spirometers that are like bedside table. You pick it up, you just breathe in and out after surgery, that kind of thing. There are fancier machines to detect more nuanced levels depending upon what your patient is experiencing or what the doctors need out of them. So multiple factors are going to be calculated with this. And now is when we get into the definition time, right? So your tidal volume, what we call tidal volume, is just your quiet breathing. That is the amount of air that's inhaled or exhaled under resting conditions. So you don't think about it normally when you're vegging out on your couch watching Netflix and whatnot. Your tidal volume is just the amount of air you are breathing in and breathing out while watching Netflix, right? That is your tidal volume. But we all know that our lungs do not create a vacuum when we're breathing in and out. Your lungs are not airtight. There is always going to be some amount of air within your lungs, right? That gives us our next two things. You have something called an inspiratory reserve volume, or an IRV, right? That one is this one right here on your list. That is the amount of air that can be forcefully inhaled after a normal tidal volume inhale. So when you're just sitting there vegging on the couch and you're just normally breathing and not thinking about anything, because I know you're like trying very hard not to concentrate on how you're breathing in or out right now. If you're just sitting there and then you stop after you've breathed in, and then the amount of air you can force yourself to further breathe in after your normal vegging on the couch watching Netflix things, that's your inspiratory reserve volume. So if you're thinking about this more in a functional use, right? I'm sitting here talking to you nicely now. We could be sitting on the couch laughing, watching BoJack Horseman or, Avatar: The Last Airbender or whatever's on Netflix now. I don't know. Right? So we can be sitting here watching whatever COVID binge we are doing, and if I decide that, wait, it's summer, we need to go outside into the pool, and I go and get a floating toy, and I need to blow it up before we can get into the pool, after I have breathed in while watching our TV show on Netflix, and I just go to breathe in all that extra air that I just filled my lungs with so I can try and blow up this flotation device for the pool, that would be my inspiratory reserve volume, right? The next one is the opposite. It's your expiratory reserve volume, right? That's the second one down on the list right here. That is the amount of air that you can forcefully exhale after your normal tidal volume exhale. So that means you are breathing on the couch normally, not thinking about anything. You're just kind of like just sitting there watching your TV show, and then all of a sudden you remember, oh crap, I left something in the washing machine last night, and now it's probably going to smell like mold and I have to do laundry again. So you just sit there, and out of exasperation, you just sigh and groan as loud as you can. And you breathe out everything that's left in your lungs out of frustration, so you feel almost empty. We have all had those moments of, why did I do this to myself? Now I have to do more chores, right? That would be your expiratory reserve volume, right? That's the amount of air that you can force out after you have breathed normally. Right? And then, because we know your lungs are not a vacuum, they are never airtight, there's always going to be some amount of air stuck inside them, right? The amount of air that is left inside your lungs after your forced exhale is called your residual volume. So whatever air that is left inside your lungs after you have exhaled everything you feel like you can exhale inside you, like even if you're sitting at the computer right now and you force yourself to exhale as much as you can, the amount of air that is then left inside your lungs, that's your residual volume, right? So this is a nice little, when you start looking at this in amounts, which air is measured in milliliters for medical purposes, you have this lovely little colored chart here that explains to you the different other definitions that we're about to talk about. You have this other word volume here, right? Right? So, and this is a very fancy spirometer, by the way, or a pulmonary function test. So you can measure literally everything and everything we are talking about in here. So here's a chart for you for putting stuff in like this into words. I'm going to simplify this by going over your colored chart right now, right? So doctors are going to use these 4 basic amounts here that we just talked about. The tidal volume, which is your normal quiet breathing. Expiratory reserve, that's how much you can force out of your lungs after you're done normal breathing or quiet breathing. Inspiratory reserve volume, which is how much you can force yourself to inhale after you have like quietly breathed. And then the residual volume, the air that is left in your lungs afterwards. Right? Doctors are going to use this information to calculate a couple of capacities, which are needed in order to diagnose some things. So, something called your inspiratory capacity. Inspiratory is in breathing in, right? So this is the full capacity of how much you are physically capable of breathing in. So this is the maximum amount of air that can be inspired or breathed in after a normal expiration. So your inspiratory capacity is going to be the tidal volume plus your inspiratory reserve volume. That's the total amount of air that you can physically breathe in. Right? So essentially that would be your tidal volume plus your inspiratory reserve volume is your inspiratory capacity, if you want to put that down as a mathematical formula. Right? But your inspiratory capacity is the total amount you can breathe in. So that's going to be your normal breathing in or quiet breathing, tidal volume, plus your EXRV. Right? The next thing to wonder about is called the functional residual capacity. Right? That is the volume of air that remains inside your lungs after a normal tidal volume expiration. So after quiet breathing, the total amount of air that is still inside you or stuck inside you is the functional residual capacity. Right? That means that is the amount of air that is constantly stuck inside your lungs, that is always going to be there because your lungs are not a vacuum, and it's the amount of air that you could then try to force out of your lungs via a forced breath. So that means your functional residual capacity here is going to be your expiratory reserve volume and the residual volume combined. So that means your FRC is going to be your ERV plus your RV, or residual volume. Right? So we're just adding those two things up. Vital capacity is another important one that doctors will calculate. Your vital capacity is going to be the maximum amount of air that you can expire or breathe out after a maximum inhale effort or inspiration. So when you are swimming, right, and you're a little kid and you have that competition with your friends, who can go down to the bottom of the pool first, right? And you're all trying to get down to the bottom of the pool. So you're at the top of the pool about to do that cannonball in, and you take the biggest breath you possibly can, and then you jump, and then you stay at the bottom of the pool trying to beat your friends to see who can stay down the longest. But you start breathing out the bubbles down when you're at the bottom of the pool trying to beat them and stack your time clock. That total amount of air that you could have breathed out from the moment you took the biggest breath in you possibly could to when all the air is left out of your lungs. That is called your vital capacity. So another thing, going back to your musical instrument people in choir, sometimes when you were in band class in high school, maybe the band director said, we're going to see who has the best lung capacity. Take in the biggest breath you can, and we'll see who finishes playing their musical instrument last. Right? That was something my band director did to us in high school to see, how we were doing with this. So you take in the biggest breath you possibly can, and then you just blow and play your musical instrument and try to hold one single note out as long as you possibly can without taking a breath, right? That is your vital capacity. Your vital capacity is your total inspiratory reserve volume and your expiratory reserve volume and the tidal volume on top of that. So everything you can actively breathe in or out, which is your IRV, ERV, or tidal volume, or TV, combined is your vital capacity. Right? And then that brings us to the most obvious one of all, is total lung capacity, right? Total lung capacity is exactly what it sounds like. It's the maximum amount of air that can be contained in your lungs after the maximum inspiratory effort. So the total amount of air that you can breathe in that your lungs can possibly hold, that means it's your inspiratory reserve volume, tidal volume, expiratory reserve volume, and all that residual volume that's you're never going to be able to push out of your lungs naturally. All that combined is your total lung capacity. Right? So everything combined is your total lung capacity with that. These are numbers and things that doctors will want to know, especially when they start diagnosing more complicated problems, which we're going to talk about in when we get to your objective about illnesses. This is going to be we'll start talking about these things because each one functions differently, right? Maybe if you're an individual with severe scoliosis and your thoracic cavity is sort of twisted around because your spine is twisted, your lungs have less space to expand, so your total lung capacity is lower than it should be, meaning you're going to have problems breathing. But perhaps you're an elderly gentleman who's been smoking for so long that your lungs now have problem pushing air out because of the way that the smoke and the tar and everything has built up in you. So you can inhale okay. So your inspiratory reserve volume and tidal volumes, they're okay. But your expiratory reserve volume and your residual volume is like insanely high because you physically cannot push air out, and your expiratory reserve volume is super low. So this purple area is really high with this green being really low. That is a disorder called COPD, when you can't get air out of you when you're breathing. Doctors will want to know that so they can appropriately diagnose you. The opposite of COPD, by the way, where you have difficulty attempting to even get air into you, maybe you are carrying too much air inside you, but you can't seem to, your tidal volume is super low, and then when you try to actively breathe in, your inspiratory reserve volume is super low because the damage from smoking for so long has just hit, right? So you can't breathe in very much. That's called emphysema, right? And no, those two are not mutually exclusive, so some poor souls can end up with both of them. But these numbers are important for doctors to be able to know and calculate when you're having difficulty breathing, so they can figure out the best course of treatment and how to deal with this, right? That's the job of all of these different measurements that they can potentially do in order to calculate this. And most of this, you have to know these 4 basic numbers, but it's just adding them up in the right fashion, right? Total lung capacity is all 4 of these added up together. Inspiratory capacity is the 2 with inspire in it, so you're breathing in tidal volume and your ERV. Functional residual capacity, it's residual, so that's your ERV and residual volume. Vital capacity is breathing in and out, because vital is what you need for life, and you need to breathe in and out to keep living, right? So vital capacity is in and out, so that's your IRV, ERV, and your tidal volume all combined, right? And that brings us to the last thing that you guys should know a little bit about, right? So sometimes, not all air, well, not sometimes, all the time, right? So there is something called dead space within our respiratory system as well. Not all of the air that we ever breathe in, or that is inspired, is ever going to actually be used for gas exchange. And I know that sounds super weird, but like I've said, your respiratory system doesn't magically create an air vacuum that's airlocked, right? So there is always going to be some amount of air that is left in the conducting zones, right? So when you breathe in, you have filled your lungs, and all of the air that reached the alveoli is being used for gas exchange, but you still have air that's in your larynx and your pharynx and your nasal cavity and even in your trachea and bronchi that was on the way to those alveoli, right? But that air is never going to reach there because you just finished breathing in, and now you're going to breathe out and then push that air out of those tubes. So any air that is left in what we referred to earlier as your conducting zones that never reaches the lungs is air that counts towards something called dead space, right? And sometimes when we have damaged our lungs, right, air that is stuck in your alveoli because the alveoli have collapsed or they're obstructed by something, be it infection or smoking ash and tar or whatever. Any air that cannot act as part of gas exchange anymore because it is trapped in a collapsed alveolus, that is also dead space. So if you damage your lungs either by accident or by own bad habits, that also contributes to the amount of dead space that's inside you, which is not good. Like, there is always going to be some amount of dead space from the air to travel. Like I said, the air that makes it all the way to my trachea but never makes it further into my lungs because I exhale first, that air was dead space, right? There's always going to be a little bit of dead space. However, you want there to be as little dead space, essentially, as possible, because if you have lung cancer, for example, and that's taken over a lobe of your lung, or a giant mass within your lung, and no alveoli or lung tissue in the vicinity of that cancer can exchange gas anymore, that counts as dead space. And that's obviously not good for breathing. That's not good for any of these amounts or numbers that we're discussing right now. Right? Yeah. So there we have it. Those are the things that you will be asked to add up to figure out on your next test. I will leave you with that right now because it's all simple addition and subtraction. I hope you have a wonderful, wonderful day.